Hi there. It's so great to be talking to you today. I'm Dr. Rebecca Meinhardt. I'm the Chief of Obstetric Anesthesia at Massachusetts General Hospital. I'm also the Network Simulation Officer for the Massachusetts General Hospital Network. So I go to different hospitals in the area and help them build up their simulation programs. And I'm really excited today to talk to you about crisis management and obstetrics and how we can better communicate to mitigate our risk to our patients and to ourselves. I have no relevant financial disclosures for this talk. And what I'd like to cover with you today is sort of a culmination of 15 years of work, 15 plus years of work, of my own work and others, just discussing what are the elements needed for best communication during a crisis. So we say that, communication needs to be better, but what does it actually mean? What are we looking for when we say good communication or best communication? I'd like to introduce an organizational strategy for crises that incorporates very essential crisis resource management principles. It's called Name, Claim, Aim. It was developed by myself and others at the Center for Medical Simulation in Boston. And we've been teaching it in the Harvard system to really help teams come together and organize themselves in a rapid and effective way when there are crises. So I'm going to share that with you today. And finally, I've done some work looking at leadership styles and inclusive behaviors and realized that actually inclusion in a team matters a lot, especially when the situation is dynamic and complicated, which I would argue are most of our obstetric crises. And so talking about how we as leaders in anesthesia can help our teams come together and have better decision making in the moment, especially when the patient is at risk. So why am I even talking about communication? We do this all the time, right? We're really good at it. It's great. It goes smoothly most of the time, right? Well, it turns out that actually not always. So these are data from the Joint Commission from 2014 and also from our own captive malpractice insurer, CRICO, which is the insurer for the Harvard Medical institutions. And it turns out that actually a large majority of claims have communication failures in them. So in high severity cases, 37% of them have communication failures, and a lot of times that's between providers. When providers don't communicate and the case goes before a jury or it goes to be closed and paid out, it turns out that when providers don't communicate, the public and others tax us heavily. So we get punished heavily. So 73% of malpractice payouts are represented in the 57% of communication failures between providers. So the public does not like this. Of course, we don't probably feel good about this. It's something that could be avoided. And these are all cases. These are, obstetrics actually overrepresents 34% of obstetric cases, and 26% of surgical cases have communication failures as well. So this means that we actually have some work to do. So, communication is essential for effective teamwork, and I'm going to share with you all of the elements that are really essential for effective teamwork because, as you know, we're not working in solo, especially in obstetrics. And so this is a model generated by Dr. Eduardo Salas and his colleagues. He is an organizational psychologist and a brilliant person. He's informed a lot of my thinking. And I'll say that there are 6 elements. And so this idea of cognition, sharing our mental, it's a thing called mental model. It's when you're looking at the patient, you kind of all together know what's happening, what might happen if you don't do essential steps. So that's sort of knowing together as a team what is happening with the patient and what people are expected to do. Cooperation is important, of course. Leadership is essential. Having coordinated efforts is important. Having the right conditions to work under, like we have our equipment, we have our room that works, our facility is robust. And finally, communication is part of this. But I would say that communication basically underlies almost all of these elements. It's embedded in there somewhere. You have to communicate to even have shared cognition. You have to communicate to have leadership skills, to coordinate. And so it's actually, I think, the most essential element that teamwork is dependent on. And again, teamwork is essential to modern day obstetrics. I don't have to remind this audience that we need our teams together. This is a simulation that we held a number of years ago. It has trauma surgeons, it has main OR operating room nurses, it has obstetricians, maternal fetal medicine specialists, it has anesthesia team members, including CRNAs and attendings and residents. And so all of these people together were managing a hemorrhage in a case of an obstetric patient who had a trauma. And so as we know, this is maybe doesn't happen all the time, but certainly things like hemorrhage happen frequently. And we need a whole team to manage that. So how I like to think about communication is actually in a simplistic form. And there are many ways to think about communication, so I'm only asking you to pause for a moment and consider this model, which is when we communicate, how much do we share information, share our planning, and how much are we asking for information and asking for plans? The reason I think about it this way is because it's actually a well-established model, and I'll share the model with you along with some more academic terms that people think about communication in. But for now, I just want you to think about how much do you share and how much do you ask. So I looked at this. I wanted to understand how people in a crisis came together and shared information and asked others for their information to better build out a team plan. And so this is a simulation-based study. I took a maternal and fetal crisis. So the mom was in trouble, the baby was in trouble, and the mom had a difficult airway, and in fact, it was an impossible airway. It needed a surgical intervention for it. And the baby was basically dying, and there was a terminal fetal bradycardia, and the obstetrics team needed to operate. So I wanted to see how anesthesiologists communicated to the obstetricians and how the obstetricians communicated to the anesthesiologists, and whether the teams came together with an understanding and a plan to move forward. So what I found was actually very interesting styles. And I looked at the sharing and I looked at the asking. So I looked at how much they shared information and how much they asked back, shared a plan and asked back for a plan. So what I found was when the anesthesiologist was communicating, mostly we, meaning the anesthesiologists, shared a lot of information. Boy, everybody was sharing. The airway's difficult, it's impossible, I can't see, all these things. So they were sharing information. Plans were such that, like, I'm going to move to a fiber optic scope, I'm going to need an LMA, those kinds of things. I'm going to place an LMA, I'm going to treat the hypotension. So those were the plans that they were sharing. But they really didn't ask anything of the obstetricians, and one can argue if that was appropriate. So I'm not sure. And the truth is, under extreme stress, and especially in airway, I think it's one of the worst kind of consequences for many anesthesiologists. It's pretty awful in its outcomes, and it doesn't have a lot of time involved that you can act. And so it could be that actually there wasn't enough time to ask. But I will say that some of the team members asked. Some of the anesthesiologists asked, and then actually some proportion of those, not all, but some proportion of those went on to make plans and coordinate better. And so I would say that from the obstetrician's end, they shared and asked in sort of equal amounts, but clearly there's a gap to close. And so there's still some work to be done. Not all the obstetricians shared information, nor did they ask how things were going. And sometimes the teams were almost like two separate teams where almost nobody was talking, and delays in care and doing weird things that may not have worked out in a real situation occurred. So I think that this just reminds us that our communication style is different from obstetricians at baseline in this group. So it could be that you reflect on your own communication style, especially when you're stressed, when there's a crisis evolving. How much do you share and how much do you ask to get a sense of the situation to build your own situation awareness? Because that's part of this. So the terms that I'll use now, I'm going to just put academic labels on them because that's what the communication literature supports. Sharing is known as advocacy. It's an unfortunate term because it means something different to us mostly, but in this context, it means sharing information and sharing your point of view. Asking is also known as inquiry. And so the bundle of these two, when you pair them together, which is the communication model that I'll share, it's called advocacy inquiry. So it's just naming the sharing and the asking, and it's putting it into a scripted form. So this is something we'll come back to in a little bit. But first, I want to just shift gears slightly and talk a little bit deeper about what is a crisis. How does that feel? What is it like? And I'd like to start with sharing some information that I've I've gleaned over the 15 years I've been doing simulation work. So I teach faculty, I teach teams, I do teach residents, but I mostly moved into the faculty space now. And, what we know about treating a crisis, as I've mentioned before, this crisis resource management principles, these are the principles that were elaborated by David Gaba in the 1980s, 90s, mostly in the 90s, that outline what are the essential behaviors to turn around a situation quickly, to have the team come together and to treat whatever the situation is. And he looked at all kinds of different high reliability organizations, such as the military, aviation, et cetera, nuclear industry, and came upon the cockpit resource management principles, the crew resource management principles out of aviation, and then renamed them to be crisis resource management principles for anesthesiologists. I would say that these are now widely applied. They're not as well known maybe as team steps, but they encompass the same types of principles. So designating leadership, calling for help, knowing your environment, delegating the roles, distributing the tasks evenly, those kinds of things, using your resources wisely. Those are the crisis resource management principles. So on the outset, those all sound like really sound principles. They make a lot of sense. If we're going to have a crisis, we need to do all those things rapidly. But what I was seeing when I was teaching, especially faculty, was that even the most experienced clinicians weren't always using these. And it would be in a simulated setting. So maybe, you could argue that that's different than real life, although we do see a lot of overlap in the simulation literature, that people act in real life and they act in simulation. It's about the same. And so if they're really into the case, if they feel like they're engaged. And so what I was seeing was that what we were seeing is that even these people who know this stuff really well weren't always doing it. And so it made us think, what is going on behind the scenes? So just like the leaves of this plant, we can see the crisis resource management principles and the behaviors being done, but we don't actually know the root system. We don't actually know what's driving that. And what that root system is how do people define a crisis? How do they recognize a crisis? How do they prioritize what they do in a crisis? So I started to dig into this with the team at Center for Medical Simulation. And one of the things we posited was that people actually have different thresholds for calling things a crisis. And this is literature that's not yet, it's work it's not yet published, but it's in process. And so what I'd like to share with you is a little bit of a model of how people might consider a crisis. And I have on this model, basically it'll be a graph. On the y-axis, the up and down axis, we have things are going well at the top and things are going not so well at the bottom. So very simplistic terms, whatever you want to say that is with the patient, with how you're feeling about the situation, whatever. And along the x-axis will be time. So, when we think about a crisis, we think about a crisis like this. We're going along in our case and then suddenly, boom, something hits. There's a crisis, everything is dramatic, it's drastic, it's awful. And I would say everyone in this audience would probably say, if that happens, yes, I would call that a crisis. I would say that's the time when I need to call for help or I need to do quick action. I can't forecast so well what's going to happen with the patient. I need to move quickly. And I would say these are part of our crises. Yes, some of the crises happen really rapidly. Airway things happen really rapidly. Sometimes lethal arrhythmias, a massive PE, something like that would happen rapidly. But I also argue that on review of our own cases at MGH, where we have anesthesia stats called, which is the emergency call out for help that we use, I would argue that a third of them are like this, and a third, look some other combination of ways, including, another third look different. So this is maybe more of the slope where things are sort of going downhill for some time period, whether that's 10 minutes, 20 minutes, longer, who knows? But it's hard to know. Do you call it a crisis here? What about here? Hopefully down here you're calling it a crisis. What about down here? Hopefully most people would be calling it a crisis by there. This curve represents our need to feel certain about the circumstance and how long we wait before we start to activate our teams and start to call in resources to help. So at this first question mark, maybe you are at a center that doesn't actually have a lot of resources to help you. So when you call for help, that's a big ask. You're calling people away from their other tasks. And so you might get a response. Of course, we would all hope that our colleagues are very collegial and grateful to help and grateful to be sent away. But we know that there's a cost to calling for help sometimes, depending on what your resources are. And so for this first question mark, maybe people sort of wonder, are you just going to call wolf all the time? It resolved really quickly. Yes, it probably resolved because of the help that was called for and you didn't know, but that's the whole point of a crisis. The crisis is a tipping point. You're not sure which way it's going to go. And so, down on the line, if you're on the third question mark, maybe the patient never fully recovers. Maybe there's some neurologic injury because the team waited to see, in fact, was this a problem or was it just going to get better with the next 3 or 5 things that I do? And so that's why this is so tricky, is that in fact, people have a different threshold for when they call it a crisis, and it's yet unknown how people define that. This is the work that's being under review, is that we've sort of unpacked a little bit about what people struggle with identifying and defining a crisis. It's pretty nebulous, depends on a lot of different things. And so within that defining a crisis are a lot of emotions too. So one of the things that came from our study was that a lot of people revealed a lot of emotions that they're feeling when they have a crisis ongoing in the operating room or in the labor and delivery suite. And so I share with you the circumplex model of emotions, which is just to talk about how people think about emotions who study emotions a lot. So on this up and down scale, intense to mild, that's sort of how extreme do you feel about the situation. Like if you have intense emotion or mild emotion down at the bottom, so that's your activation. And then across the x-axis, side to side, is the valence. So is it unpleasant or is it pleasant? And of course, what do you think? In crisis, most people were talking about this quadrant, this intense and unpleasant, the intense and unpleasant feelings that came up. A couple people decided it was more of a challenge for them, but most people felt that it was distressing in some way to have a crisis. So as the anesthesiology provider who is managing the crisis, they were experiencing these emotions, and they were generated from a lot of different things. So the emotions can impact our thinking, actually. So that's a really important, I think, new piece of information that we're linking together. We're trying to link together these things. And so it turns out that emotions just aren't like, you don't just suppress them and they go away. They actually can really change how you think, how you take in information, how you process information, how you share with your team, and then how your team's emotions are. We generate emotions between each other. We influence each other's emotions a lot. So this is really an important piece of it. So when we're under stress and we have these negative emotions, it changes how we think. So this is work done by Amy Arnston, who was a neuroscientist, and has basically studied the effects of stress on the brain using advanced fMRI techniques, functional MRI, those kinds of things. And so what it turns out is that even a brief little bit of stress can change how we think and how our brain can organize our thoughts. As you can see on the right-hand side of the screen, there are 2 pictures. And all I want to show you is like the top picture has the prefrontal cortex, which is that nice bluish green in the front. That's the executive center of the brain. That's the CEO of the brain that helps you direct your thinking and helps you invest resources in, like, if you want to think about algorithmic or arithmetic or something like that. It helps you organize your thinking and deploy your neural circuitry in ways that will help the situation. Down below, you see the hypothalamus, the amygdala, all of these places here, and those are sort of deeper structures that deal with emotion and are very sensitive to emotion. So on the top, you see everything is working well. The CEO of the brain, which is the prefrontal cortex, is talking to all these other centers, and it's communicating back and forth, so it's organizing things really well. Down below, the NA and the DA are noradrenaline and dopamine. So when you get a burst of catechol, what happens is you shut down your prefrontal cortex. So even mild acute stress, even a threat, a little surprise in the middle of a case can give you a burst of catechol enough to shut the circuitry down. And then suddenly you're driven by your emotional centers. And that's, this is indicated multiple times. If you are standing in an elevator and you're relaxed you're having your coffee, and then suddenly somebody comes up and says, hold the door, as the doors are closing. You're trying to push the button, you don't know which button to push because they look funny, they're the arrows that go in or out or whatever. That's the result of acute stress, even though it's not a real threat. Acute stress disrupts your ability to organize your thinking and decipher what those arrows mean on the elevator buttons. It's called the amygdala hijack. And so what happens is, if we are under a lot of stress, like what happens in a crisis, our performance is actually impaired. We can't think. We need our cortex to have these higher order thinking, to puzzle through what the situation is with the patient. And then we can't do that when we are under stress. So we have to find ways to decrease our stress. And one of those ways is talking aloud and taking deep breaths. So those are two strategies to regulate our own emotions. And our emotions definitely impact the team, because most of the time on obstetrics, the obstetricians are looking to the anesthesiologists, the anesthesia providers, to save the day along with them. So let's talk about how do we work together to have better communication. I mentioned this advocacy inquiry before. So this is good for situations where you think maybe something is starting, but you're not sure. And so you want to just sort of get a sense for what the other person is, what's happening for the other person. So it actually pairs the advocacy, which is sharing your point of view, with asking what the other person thinks. And it's an open-ended question. This is a language pattern that I teach a lot. It's hard to adopt at first, but once you do about 100 of these, it gets really quick and facile. And the truth is that this is born out of decades worth of business literature, organizational behavior literature, communication literature that shows that this is the quickest way to get into somebody else's head and then to make a joint plan. So it starts off with something like, I see that the patient's vital signs, patient is hypotensive and tachycardic. I think there's probably bleeding, even though you're saying, I'm not sure, you're saying that there's not any, but I'm seeing a disconnect. And so that's the advocacy. I'm sharing my concern. I'm sharing what I'm seeing, the data, and then I'm asking them, so what do you think? So what do you see down there? Help me understand what you're seeing in the field, in the surgical field, or that, delivery, with the delivery. That's the inquiry part. So I'm not asking, is she bleeding? I'm saying, what are you seeing? So I'm asking an open-ended question, and that's really important, because if you ask yes, no questions, then somebody just has to think about each question as you're asking it, instead of just sharing what they think. And then you're listening to what they say, and then you're talking about what you should do next. So this formula, I would say, is super helpful for quick, efficient, effective conversations. I would encourage you to think about, how do you speak up about stuff using this model, and practice it once or twice a day. If you're talking with surgeons, not just obstetricians, I feel like obstetricians are a little bit more, it depends on your obstetricians, the culture of the surgical group, the culture of the obstetrician group. For me, I would say our surgical colleagues more expect people to share what they've done. So what I've done is, if I'm in the operating room, the main operating room, I will say, I do the I saw, which is, these are the data I'm seeing, what I've done about it. So if there's hypertension, I've been giving fluids, I ordered blood, I've been giving pressors, with escalated pressors, I've added a second pressor. And then, so when you add this part of it, I think it matters, because surgeons, from what I understand in the culture at MGH, they never share a problem without telling people what they've done to fix it. Because if they share a problem but they haven't done anything to fix it, that's just antithetical to surgical culture. They're there to fix things. Then I share what I think about. So I've been escalating pressors, whatever. I think there's a problem with bleeding or something. I'm not sure what's going on. What do you see? What do you see in your field, to help them come to me and share with me what's going on for them? So now I'm going to share briefly this model of how we organize in a crisis. And I'm going to go through it pretty quickly because we don't have a lot of time left. But what we've designed is a system called name, claim, aim. So when there's a crisis, I'll walk you through what are all the bullets that we do. So the first part of it is, there's a crisis that happens. If I'm standing here and I see the rhythm looks okay and then it doesn't look okay, there's an oh no moment, where in my head I'm thinking, oh no, there's a problem coming. Here it's a big problem. We got to fix it. So as soon as I recognize this, I'm calling for help. And then the first thing I do, instead of asking people to do stuff, is name what's going on. This is the most important step. If you remember nothing else from this model, I want you to remember this. When people arrive to a crisis, most commonly what I have seen is that the person who called is asking them to do tasks and doesn't orient them to the situation. And what happens is you get a lot of uncoordinated efforts, and people don't actually know what they're treating. And so then they start to break off and splinter off and have side conversations and ask each other. And then they might disagree because they're seeing bleeding, but they don't recognize that you actually were in the middle of sepsis and DIC. So there's a whole disconnect that can happen if you don't name. So naming looks like this. We have a problem. Usually this is happening the first wave. So this can happen in waves. So the first time I look over and I see VFib or torsade, I might say to the surgeon, we've got a problem. I have no pulse. I think it's VFib. And then we'll move from there. The next two things that happen are claiming and aiming. Claiming is claiming roles, designating the roles, and also claiming leadership of the organization. It doesn't have to be claiming that, if people call it team leader, you don't have to own the whole plan. You're there to sort of figure out together as the team what's going on and what needs to happen. You might have the most ACLS knowledge and training, but you're also looking to treat together and use all of your team with all of their brains to figure out what the best strategy is. Aiming is what task do you do? And I like to think in my own head of like just minimizing the tasks. The next three things we need to do, because then that allows people to catch up, and then it allows people to share their own information and own ideas, and it gives me a break to sort of survey and figure out what's going on. So the event manager and claim is inclusive. We need all ideas. I'll help organize this. We need all your ideas. So it's explicitly inclusive, and that's super important to get people to speak up, because especially when crisis is happening, people are not going to want to speak up. And aiming says, these are the next three steps that I want to do. Does anyone else have any ideas? Or what other ideas do you have? Asking that kind of open-ended question, what ideas do you have, is important also for having the team speak up, because they will see things that you do not see. Always they will. And so using your team as best you can is super important. Now in practice, I start with the name, and I myself do aiming and claiming sort of together. So I might say, can you do an IV? I need you to do an IV right now. So that's both designating a role, which is the claim part, and also giving a task to do. So I might do that. And then you're renaming and re-aiming as your situation changes. But the renaming is super important. So we did have VFib arrest. Now we're back. We've gotten ROS, return of spontaneous circulation. Now the patient's just really hypertensive. We've got to figure out if this is a cardiac event. So that's sort of the tempo. That would be what a rename would sound like. And then renaming would be, now we got to get a cardiologist in here to help us figure out what's going on. Maybe the cath lab too. So all of these teamwork principles and the inclusivity that I've kind of alluded to, is it's essential to build psychological safety. And psychological safety is this really powerful concept that it shares basically that everyone in the team feels safe to take risks, to share what they know, share their information, and they don't censor it. And so inclusivity builds that. And I'm going to go through inclusivity very quickly in the last minute and a half. And we're talking about leadership, and you can be a leader as well. Of course you are. So the leadership behaviors that I looked at recently in this review article range from what I think of as authoritative to inclusive on sort of a spectrum. And I'm going to describe them really quickly. Authoritative behaviors, I think, are what we see most in the OR. They basically are driven from a leader, nobody who doesn't invite the team members, who encourages the members just to submit. And there's motivation through threat or reward. And this can sometimes work, but it usually is only helpful for straightforward problems, novice teams, algorithmic solutions, and people have a lot of stress. Inclusivity, on the other hand, is super important. It actually encourages teams to elicit information from the leader. The leader then responds constructively, even when the leader disagrees with things, encourages the team as a team to be motivated, and then includes ideas. So this is really important for these types of situations, complicated problems where the coordinated solutions are needed and the team members are actually in control of themselves and have experience. And so I would say the benefits are numerous, and basically the information sharing and engagement of the team outweigh any of the problems. Some of the exclusive behaviors I use are to ask explicitly, what are your ideas? If I disagree, I'll say thanks, we'll come back to that. Using we language, including members' ideas. And then I just want to remind you, it's not about being friendly. Inclusion is not about being friendly. It's about respecting all members of the team. And so I know I'm over time. Thank you so much. I just want to share some summary tips, which is how can we ask questions of others? When can we ask them? To use this model, I saw maybe what I've done about it. I think and I wonder. Considering using name, claim, aim to organize the team. And finally, consider using inclusive behaviors to build more sharing in teams to have better decision making because you have better information. And I thank you so much for your time, and I'll take questions. Thank you.